right, everyone. We're going to reconvene. This is our last keynote. You can get up and stretch. Hopefully you went to the bathroom, had some snacks and coffee, you're re-energized. So it's really my pleasure to welcome Shannon Bryan. She is the Substance Use Disorder and Substance Exposed Newborn Specialist for Colorado's Office of Children, Youth, and Families Division of Child Welfare. Shannon has a master's in public health with a focus on family and child health, as well as 10 years of experience leading and facilitating multi-system projects to improve outcomes for children, youth, and families involved in the juvenile justice, child welfare, and mental behavioral health systems. So truly an expert in the field who has been leading the charge in just solving this very simple problem, right? of the intersection of child welfare and healthcare. So thank you.
Thanks, Susan. And really, I would say I'm piggybacking off of the great work that has already been done by Chosen and so many folks in this room. So, but it is really complex and sometimes not super awesome and sometimes awesome. So, all right. So really the focus of today's presentation, as many of you probably have experienced, you're like, yeah, okay, we hear from like one person that this is the definition of abuse and neglect, or this is how child welfare response works, but we experience differences when we interact with individuals or when we interact with different counties. So I'm going to attempt to explain in more general terms why some of that variation exists and to demonstrate where some of that variation can really play out and how we all work together. And then end with talking about, some ideas for how you all can work kind of at a more local or regional level to increase understanding and collaboration and coordination because there is that variation. So that's essentially what I just said. So the playbook. Colorado child welfare is governed by one playbook, right? So that is all defined in our Colorado Children's Code or Title 19 and our Volume 7, which is the Social Services Rules and Administration. This is really what governs child welfare. It's what tells us what the definition of abuse and neglect is. It tells us how we need to assess for safety and risk. It tells us our response time. And even within all that, I mean, if you've ever read any federal law, any state law, or even just like local policy in your hospital, right? There's still a lot of vague pieces in there. There's still some wishy-washy pieces in there. And there's still interpretation by humans. But we do have very clear rules and responsibilities. We have a 4-page document that we have to walk through, and we'll go into that a little bit more. And some of this may be a little bit redundant if you were in some of our other presentations earlier, like a breakout session earlier today. So apologies, but I think it's always important to kind of understand and re-emphasize some of these broad points. So this is, again, the general outline of how the child welfare system works, how we should be responding. This is what we do. And this is all publicly available. And again, it's all defined and publicly available in our Volume 7 in Title 19. But essentially, right, someone calls, a group of folks will review the call or what we call a referral to see if it meets criteria. Does it even do the concerns even fall under what abuse and neglect is defined as? It is either screened in or screened out. If it is quote unquote screened in, it goes to assessment where more information is gathered. What I'll say is, so first of all, no one is making a decision to screen in or screen out by themselves. That has to occur with a minimum of 2 people and approved by at least 1 supervisor. So no decision here is just one person making a choice. So there's a little bit of built-in questions that go into there. Screening. The local county Department of Human Services will review the referral again to determine what is the allegation. Is this allegation even something we should be considering? Because sometimes, honestly, it's not. We do sometimes get folks who are like, we just think that they need more access to service, like to financial resources. It's not that doesn't fall under our definition of abuse and neglect. So we would screen that out. But based off of that, we would say, okay, well, does it meet those basic definitions? Then we do a safety assessment, and we also look at these things and say, what's the response time? If the concern is there's a current immediate danger right now, then our response time is much quicker. If the concern is, we think there's impending danger, like it could occur in the near future if something's not done, we might not respond for a little bit more time. But again, those are all really clearly defined by us. It's not something that we're making up. We have to refer to these rules and regulations and these 4-page, 5-page documents, talk together and talk with our supervisors before making that determination. So yeah, and if a referral doesn't meet the guidelines for assessment, it's screened out. The family may be referred to community resources to address their needs or a prevention services team if it's available. We're going to get into that into a second because again, there's differences when it comes to counties, but across the board, this is what screening means in every county. Across the board, this is what assessment does in every county. If the referral is assigned to a caseworker to assess, that's not meaning they're going to have an open case. It's like, okay, we got a referral. Yes, that referral and the allegations in there meet our definition, but we don't really know if we have enough information here. So we are going to try and get more information to consider if there's an effect to the safety and well-being of the child, like what's going on. Based off of that, they consider, the referral is assigned. They have to consider contact the family either immediately. So again, if there's a huge safety risk and it's like, this kid is in current danger, it's actively happening, this thing is active, they respond immediately. By the end of the 3rd calendar day, if it's like, well, the child, and in your case, sometimes it's like the kiddo is in the NICU, we don't have it. If we release the kiddo and do a discharge, there might be a concern, but right now they're safe in our NICU. We're able to control for some of those safety and risk factors, or within 5 working days. Again, there's a lot of variation that goes into this, and that's where really the conversation with you all comes into play, but also not just with you all. There's information we need to look at within our systems and conversations we like to have with other folks that we call collaterals that are maybe family members. It'd be great if there's peer support available and other family members. So response time is also based on what is the safety concern, what's the level of danger or risk or harm, and also what's the vulnerability of the child. So when we're talking about this population, these children are extremely vulnerable because they're 100% dependent, right, on their caregiver for their needs. Now, vulnerability of a child may change as they get older, and so that's how that comes into play in this conversation. Okay. I do just want to say there are training resources about understanding abuse and neglect and what is that definition, what is the role of mandatory reporters. That's all publicly available on the Colorado for Kids website. So just throwing that up there, we're going to go right by that, but that is available if folks are still like, well, what are all the different definitions of abuse and neglect if you want to learn more about safety and risk assessments. But again, we might have a playbook, but there's different plays. I think Raquel I don't know where she might have left, but she also used a football analogy. And so while we have these broad definitions and we have these specific kind of flows we need to follow, there's still some variation. And that's mainly because we're what's known as a state supervised county administered system. And what that essentially means is that as the state, we need to make sure that each county is meeting those federally and state defined requirements. That's our job. We oversee that practice to make sure that's happening. We provide policy direction, best practice recommendations, and we distribute funding to the counties. But counties have a broad ability to adapt within their communities to the specific needs, resources that are in their communities, in their counties, in their regions. So there's a lot of variability there. For example, some of our counties honestly are literally 4 people for 2 counties. They oversee child welfare for 2 counties, and they're not just they're not just child welfare specialists, they also do adult protection. But then you have other counties that have 5 different teams just in child welfare, right? Because they have the staff, they have the capacity, they have the resources. And so there's that much variation when we're talking about our counties, again, to meet need, capacity, resources. So it's really, that's just how it is. Jurisdiction, I know this comes up a lot. This can also impact how you interact with different counties. So one thing I will say is not every county is its own judicial district. So that's important to know because different courts, court systems understand and interpret things differently. And some counties, I think maybe only like 2 actually, have are the same judicial district. So 1 judicial district in 1 county. It gets difficult, right? If you're working with a family who's experiencing homelessness or is unstably housed, you don't necessarily know who you're going to be interacting with. But here it kind of is what we follow in terms of where jurisdiction may lie. But this might also be why you interact with a county differently at different times because of the fluidity of where a family may be located. Okay. And then you may also have heard that we have 2 different tracks now. So we are known as what is known as a differential response state, meaning that we have 2 ways that we would conduct an assessment with a family. This was discussed in one of the breakout rooms. So I think a lot of this was already covered. While there are these 2 different tracks, they still both look at safety and risk factors and protective factors of the child and their family. Really what this is what is the level of concern, safety concern or risk? If it's really a minor or moderate concern that folks feel can really be handled by kind of a lighter approach and more community support and resources, then we will go with what's known as a family assessment response. And that is a lighter touch. There are no findings at the end of that. So there's no court involvement because it was like, okay, this family needed support. Yeah, there was some risk. Honestly, we all experience risk, right? So there was some risk. They needed some supports. We got some supports in there, and then we're no longer necessary. Higher risk assessments are for those higher acuity families where really more eyes are needed. And who gets to kind of put into which track, again, is really defined in our statute. But there is some of that wiggle room because how do you consider safety? What are the questions you ask there? How do you assess risk? What are the questions you ask there? So it can this is where, right, training on bias, understanding some of these medical concerns really comes into play because just like for you all make different decisions on whether or not to report because you all have now seen in different ways what is the definition of abuse or neglect as it relates to prenatally exposed infants. And you're like, well, I don't know. What is affected by and threatened by? And there's a certain grayness there, right? Where we all are trying to learn and improve our understanding of that. The same thing is happening for our caseworkers. There is just so much there where we have to really understand what is the impact to the child, what are the physical, behavioral, psychosocial effects of a substance on a parent's ability to consistently kind of demonstrate a protective capacity to keep their child safe. But not just that, what are the protective factors that can support a family? Because again, we all need help. And so maybe I may struggle in one area, but I have enough protective factors to support me that there is no concern for the child. Okay. Prevention teams. This is another reason you might experience something different. So some counties, not all, have what's known as a prevention team. So Colorado and most of the child welfare system across the nation is really saying strengthening families and their connection to the community is the most important thing to reduce the need for child welfare involvement. If we can do more prevention, we can reduce the risk factors that all families experience. We can help build protective factors and keep families together. This has really been kind of doubled down on and invested in since the Family First Prevention Services Act was passed. And now we've received funding as a state to invest in prevention and child welfare prevention services. But again, it looks different in every county. So some counties have their own prevention team under human services, where if a referral comes in and they're like, you know what, this doesn't really meet the definition of abuse and neglect. Yeah, we see that you have some concerns and there's some risk, but there aren't these like glaring safety concerns. Then that prevention team may reach out and offer some support and some services, but they would be 100% voluntary. If a family does not participate in them, there is no kind of retribution or retaliation, because again, it's completely separate. It's not a child welfare response, it's a prevention team. Other counties have prevention services built that they pay for and provide within human services. Others contract out. Some have a robust array and have like multiple like home visiting programs. Some have one, some have none. So that is really determined by the counties, not by the state. They have the ability to choose how they're going to use their funding that they receive based off of, again, their capacity, the resources available in their community. And I know that this is frustrating because you're like, well, we want all of these services to be available to every family, and we really want there to be consistency. And we need to be responsive to the differences that are in communities, recognizing the different cultures and communities that are out there. But this is why you may see a different response. Also, there are a lot of different players. So you may specifically interact with child welfare staff known as caseworkers or hotline staff. And, hotline staff are the ones who are receiving those referrals when you call. Caseworkers are the ones who are coming out and working with you or working with families. But there's also child welfare caseworker supervisors, and they have to approve decisions to screen in, screen out, to ask for a removal, to not ask for a removal. So there's that. And then there's also county courts. A child welfare worker cannot remove a child from a family without a court order. So county court education is really necessary. I think another thing that I've heard a lot is like, well, why, we have these toxicology best practice guidelines coming out. Some counties don't require us to provide a toxicology test or tox screen. Others are asking us to complete one. Why is there this difference? And yes, we did remove reference to federal toxicology testing in our definition of abuse and neglect. And sometimes it's the courts who are like, we need this. And so if a judge is asking for that, you may be hearing that they're asking for it from a caseworker, but it's not necessarily the caseworker who's asking for it. Or you may have it where, they're really trying to determine what is the level of risk and safety. And so some counties may have a little bit more fear or concern, but we also don't know what's on the back end, right? So you're seeing the person in front of you, and child welfare may be looking at, whatever else is in our database. So that's where you start seeing that variation, because we can't necessarily say, well, we have an active case and there's these concerns, and I did not know this, but someone was like, we've actually had clients who have asked us to get a toxicology test because they want to prove to the court and the judge that they are doing well. So there's that variation. Then there's law enforcement. So sometimes law enforcement can show up, and because of whatever instance is happening, that law enforcement officer can choose to take custody of a child. That process is very different than child welfare, going through a supervisor and asking the court. That law enforcement officer has a very different process to decide if they're going to take custody of the child. And then they call child welfare, and we have to take that custody from that law enforcement officer, right? Because we don't want law enforcement to continue to have custody of a child. So there's that piece. And again, that can really change based, again, off of your jurisdiction. What's your law enforcement look like? What's the relationship there? And then there's county attorneys. So each county has a county attorney. They are providing legal recommendations and guidance for caseworkers and for supervisors. So again, when there's conversation or there's grayness or there's, hey, we have some caseworkers and supervisors over here saying they want to do this, but we have others over here who have a difference of opinion, that county attorney will provide the guidance of which way to go. And so I'm saying this because it is a lot, just like your systems are a lot. I think there was that presentation from the keynote of like all those bubbles of all those different teams and hospitals. There are so many different teams that are interacting to work with families even outside of the hospital. And so child welfare may be your face that you're seeing, like, okay, I see the child welfare caseworker, but there are all these other people who are coming into play in that decision. And that's why we can change a definition of abuse or neglect. We can start putting policies and practices in place, but it's so much more than just training our caseworkers. It's also what are those connections to all of our other systems. And that just takes so much time. I'm going to try and go faster. Okay, so this is good. So what this might look like in practice. Okay, you guys may have seen this at this point, our definitions of abuse and neglect. One thing I will say about this though, the definition of abuse and neglect, when you're thinking as mandatory reporters, right? You are required to make a report to child welfare if you know or suspect that abuse is occurring or there is a concern for the safety and well-being of a child. And I hear a lot, well, this is really difficult for us to know if we don't have a relationship with this family. So one, awesome if you have some peers in the room, or if you have already established that connection with the family, if you have some outpatient like OBG folks who have already developed that relationship, super helpful. And we have this affected by alcohol, substance exposure, threatened by. These are really the things that we as caseworkers or folks who are receiving those referrals, this is what we are held to. So you may be like, I don't know. You may be looking at this and land on, I still don't know. When you call and make that referral, we go through everything we know, which may be more, and we have to, again, look at it according to what's written in our rule and statute, along with, right, there are other reasons an infant might be at risk. So when it gets to us, we're not just looking at this definition of abuse or neglect. We have to make sure there are no active immediate safety concerns. So we are looking at all of the potential reasons, not just this. When we are in a group and we are asked, okay, so we got this referral for a prenatally exposed infant. We're working as a team to look at this referral. These are some of the questions we go through together as a group. We're asked, what are you most worried about right now? How does this worry relate to the safety of the child? We do scaling questions, okay, how worried are you on a scale of 0 to 10? What would move you from a 5 to an 8, right? Like we ask those questions because again, we could get more information. So what would move you on that scale? Then what questions can you ask the family and collaterals to get more information about the concern and to move that number? What additional information might be helpful? And also what fear and bias might come into play. I think we talk about this a lot. I know in your systems, you're trying to address it. We're trying to address it in our systems as well. What I would say is, caseworkers work with some across the board in a tough situation and see some tough things. And how might their fear come into play if they had a child fatality like a month ago? How is that going to impact the way they're looking at this referral now? Even though we have those clear definitions, even though we have those like forms that we go through, it still plays a part. And so yes, we were trying to work in teams, but it's still something that we're trying to address because it's still there. And that still impacts how you all may see someone showing up and how they may respond. So here are 3 scenarios. I'm really upping the ante by saying they're scenarios with prenatally exposed, being prenatally exposed to fentanyl. But in scenario 1, the infant was identified as prenatally exposed to fentanyl, shows signs of NOWS. It's a first-time parent. There's no other supports in the home. They're recently engaged in treatment and recovery services, but they're engaging positively with the infant and participating in parental education. So for you all, just, gonna bet in this room, there are variations in terms of concern, right? If we go back to these questions, I bet people are all over the place, right? And there's more things that we need to know. And I would say in this scenario 1, I have seen that they could be, potentially more information could be received that person could just be referred to prevention services. Or they could be referred for the family assessment response. We need more information. There's some risk here. There's some real safety concerns, but we don't think that it's that high. We think we can get it, we can control for that risk and safety by connecting to services and supports. So we're going to do this kind of lighter touch. I've seen it go both ways. Second scenario, infant identified, again, prenatally exposed to fentanyl, shows signs of NOWs. This caregiver has previous child welfare involvement for substances, but isn't currently involved, is currently living with a family member, actively engaged in treatment and recovery services for 6 months, including MAT or MOUD, engaging positively with the infant, participating in parental education, and so are their family members. This scenario, again, if you go back to these questions, it's kind of, I think some people would land differently, right? And I could see this going as screen out, right? It could be screened out, or it could be a FAR. And this again is because there's conversation here and there's more information that is asked and looked at and received. But technically, if we look at the definitions, we look at what is safety and risk, we look at does it meet the definition of abuse and neglect as defined by law? It does. So the variation is in that education, that training, those conversations, collaboration with other folks, including healthcare providers, including peer supports, including doulas. Scenario 3, infant shows up with signs of neonatal, with signs of NOWs. The caregiver lives with a spouse, is engaged in, we don't know if they're engaged in treatment or recovery, but this person's appearing lethargic, not engaging in education, and staff overhear the spouse making plans for the family to leave without a discharge plan against kind of medical clearance. That would likely be an immediate response because there are, right? So there you can see some much more clear safety concerns, but an immediate response doesn't necessarily mean a removal. That means a caseworker is going to show up more quickly and is going to ask more questions. And maybe in that, we actually find out the person's lethargic, 1, because they gave birth and that is exhausting. 2, maybe they have low blood sugar concerns or diabetes. Maybe they actually are really engaged in recovery services and we just didn't know at the time of the call. And so that information wasn't captured in that referral. Maybe staff overheard wrong, right? There's a lot of information still not captured, but this is the information we receive in a referral, and there's some give in how we respond. And there's always more information that on our end we'll need to get to determine our level of response and involvement. So I know in this room there's a lot of concern of how do I know when to call? I don't want to over-report, but I also don't want an infant to be, at risk or potentially die. So I will say in 2022, we screened out 41% of referrals for infants prenatally exposed to substances. I don't have my 2023 numbers yet, I'm sorry. And I know I'm running a little over, but these numbers are important. Okay. So we screened out 41%. I would never say to the people who called, okay, I wouldn't say I would never say. We don't want to say, hey, you should never, you were wrong to call. Maybe you didn't have enough information, right? We do want you to be thoughtful. We want you all to increase your understanding and education. We want you to have more conversations with your families. And if at the end of all of that, you're like, you know what, I really don't know. I just don't know. The whole reason for me to be here is to say we actually have developed a lot more checks and balances on our side where we're like, okay, so they called, they didn't know. Yeah, we had more information. We checked it out. We screened out 41%, or no, I'm sorry. We screened in 41%. So we actually screened out more. I'm sorry, opposite numbers. So we screened out 59% and we screened in 41%. So we're screening out quite a lot of the things that are coming in. I know it's a very different story when I get the numbers right. So that's important. And again, not saying that someone did something necessarily wrong, but we have developed checks and balances within our system to better understand what's happening for a family and identify if we need to become engaged. In addition, while we did screen out that 59%, people are like, well, did they just come back? Is more egregious? Is fatal, near fatal? Like, was that okay? Are babies more at risk? We found that of the 59% that we screened out, that we said, nope, they don't meet our definition, we do not need to become involved, only 33% came back to us within a year for another concern. Out of that 33%, 90% were for a minor severity, meaning something like they probably went into our fire track and needed more support, more services to wrap around them and to help them feel more safe and to meet the needs of their kiddos. The other thing is we've seen a steady decrease actually in our removal of infants prenatally exposed to substances from their caregivers. It's still higher than I think any of us would like, but we're seeing a decrease year over year. When I get my 2023 numbers, I can tell you if it's like consistent. But we've also seen a significant decrease in our termination of parental rights. So sometimes families do need involvement with child welfare, right? And a kiddo may need to stay in the NICU. They may need to go someplace else for a little while their birthing parent is recovering. But our reunification rate is off the charts. And we went from, in 2021, we had 209, what's known as termination of parental rights. In 2022, so after we've started doing a lot more intention and work, we had 59. So that's a huge change. And so I think there's a lot of amazing work happening in the healthcare world. There's a lot of work happening in the child welfare world. We need to increase our understanding of those changes and supports because one, I don't want to demonize the healthcare world, right? And I don't want the healthcare world to be afraid to call child welfare when they have a question or concern about the safety of a child. And I want families to know that child welfare is working really hard to not get involved when we don't need to get involved and to do the lightest touch possible because we know it's better for families. So the more we can educate each other about what's going on, I think the better we can support our families and meet their needs. So the last thing I'm going to land on is what you can do. I will just say, please organize your efforts internally. I have had conversations with counties where healthcare providers are working, a hospital system is working with my county, but other people in the hospital, in the same hospital system don't know. So we have a bunch of people reaching out for system change work, and it gets really confusing and messy. So I think, again, we have small staffs, sometimes just 4. So if folks can be internally organized and there can be kind of a central effort for that systemic change, that's helpful. But also if you have concerns about a person, about a specific issue, you can always reach out to your local child welfare department. You can ask for a supervisor or the director. You will get connected. This website, and you'll have this link, it gives you the direct link to, it's called Human Services for each county. But when you call, you just ask for a child welfare supervisor or director, and they will connect you. And develop cross-training opportunities. I can't underscore that enough. I think we've seen some really great examples, but the more our teams can understand your teams, the more your teams can understand our teams, the better. And the more we can increase that education and awareness, the more we can decrease stigma and bias and fear, right? So then we can decrease the touches and the system involvement that we have with our families. The end.
One or two questions. Time. I'll get us started. So you mentioned that there are some counties where child welfare is better integrated, perhaps in greater communication with the healthcare system. Is it reasonable for folks for many of us who work in hospitals to literally pick up the phone and call our local county child welfare office and say, can someone from your group come to our hospital and be part of our chosen team? I mean, is there a consistent individual within county level child welfare systems that can be part of chosen teams? Is that something possible?
So I would say most counties would want to participate. It may vary in terms of who it is. So for example, I was talking to Denver. They were like, we want to create a a hospital liaison position. They have different folks, but we have like a manager and a supervisor who are engaging. What's interesting though, is they were engaging in, someone was talking about like the Denver Health's rapid improvement thing. Our child welfare folks were working with them, but not with another team. And so I think, again, the more you can internally align the system efforts so that, again, you guys are big systems. So yes, you can call the one number that is on that link. You can say, hey, I'd like to talk to the child welfare like director or supervisor, and then they'll connect you to the right person.
Yeah, I'll add that as much as, many of us kind of moan the fact that we're a county kind of focused child welfare kind of delivery state. And it sounds like in the Rocky Mountain region, that map was very startling to me, that we're the only one in the middle of the country that is set up that way. But as that is, I wonder if there is a silver lining that working locally within counties perhaps allows local team formation and more ease of collaboration.
So, I mean, I think for example, you may have heard in the breakout sessions with Arapahoe having, a nurse embedded in that team and being able to respond to families in that way. That works really well for them. That may not work very well for some of our more rural, small communities, or it might work great, We also have in Larimer County some really cool things happening that they've had a long history, but then they just got connected with their outpatient folks. That works really well where there's an umbrella and where like most healthcare is provided by one large organization. That might not work as well where healthcare is more fragmented. And so a different approach would be necessary. So there is some nice flexibility in being a county administered state. And there's some unique challenges too.
Thank you. I'm curious if there's any best practice recommendations about how to communicate with families about the level of integration. As we engaged in some of these conversations with Larimer County, we did some kind of gut checking and realized that it was a potential level of alignment that crossed a boundary in terms of who we were most aligned with. And we had to really, and we are going to continue to have to really monitor our collaboration with the county and with the criminal justice system that they de facto represent. And when that pulls us out of the primary alignment with the patient, and I'd be curious if you have thoughts on that or best practices related to that tension.
Yeah, I think two things. One, cross-education opportunities are just cross-education opportunities, right? So you don't necessarily have to marry your policies, but I think having regularly standing at the minimum trainings where child welfare folks can learn about what is the response to nows and what actually are the concerns or not concerns related to the medical, like taking care of the medical needs of this fragile child. If folks can learn more about that, then they can also better understand what is the level of risk and safety when I'm reading this referral. So that cross-education is really helpful. Also for the county level side of things, right? Like, who am I talking to? And like, what do you have a prevention team? Who are my families being referred to? And if not, then like, what is your understanding of risk and safety? So I think creating some of that dialogue is important, I'm not gonna say but, and I would say in everything, whether it's cross-training collaboratives, whether it's creating shared tools, whether it is creating some like system mapping, I think it's incredibly important to include family voice, incredibly important to get some of those lived experts into the room to really help say, so for example, county has worked with a hospital system to create a business workflow of like how to create a plan of safe care and all of that. And they identified pain points and they're like, well, this didn't work for our healthcare providers. And this is where it really hurt and got confusing for our caseworkers and blah, blah, blah. I think this, like in mapping that, it's going to become more and more important to also be like, and this was the impact of this mess on my family. on the family I was working with. And this is what it felt like for that individual. And this is the outcome that happened. So I think one, there's never a downside to increasing education of each other's systems. Two, you really need to increase the integration of family voice in a meaningful way, not just like, yeah, we asked them to look at this document, but like in a meaningful developmental way. And you need to track your data. You got to track your data to see what are the outcomes, what's happening here. Are we seeing better outcomes for families? Are we seeing an increase in adverse outcomes? What does it look like across those racial and ethnic lines? So those would be my 3 things. Communication's always good. Include your families and look at your data.